Hello, everyone. My name is Mariam Zolnouri, and I am currently assistant professor at Columbia University Medical Center. My background is biomedical informatics, and I'm thrilled to be here today to present our recent work on MCI-ED screen. So MCI is a mild cognitive impairment, and ED is a early dementia. This study was funded generously by A2 Collective Program, and it's focused on developing a speech processing algorithm for early detection of mild cognitive impairment and early dementia. So currently, 1 in 5 older adults over age 60 have MCI-ED. However, unfortunately, more than 50% of the patients with MCI-ED are undiagnosed. Although existing biomarkers such as MRI are sensitive enough for detecting cognitive impairment, their application in detecting MCI-ED are limited because of high cost and perceived invasiveness. Despite national efforts for the timely diagnosis of MCI-ED, projections indicate a significant challenge ahead. And the challenge is that by 2050, it is expected that over 14 million patients will be diagnosed with MCI-ED and with associated costs exceeding $1 trillion. So the unmet need here is to improve diagnosis of MCI-ED using routinely generated data in clinical setting, reversing the progression towards Alzheimer's disease and dementia, and reducing the risk of negative outcomes. So one of the potential solutions is to use patient speech for detecting of mild cognitive impairment. But why speech is important? The study of vocalization in humans applies the source filter framework. So the source is located in the larynx and it generates vocalization. The airflow exhales from the lung oscillated the vocal folds, and the basic rate of vocal fold oscillation specify the fundamental frequency. The sound waves produced by this oscillation travels through pharynx, which is here. That is the oral and nasal cavities that can comprise this, they call it vocal tract. In this process, the vocal tract filters the sound, so amplifying certain frequencies and attenuating others, therefore producing resonant frequencies. So from F1 to F4, there are resonant frequencies, and F0 is fundamental frequencies, which is related to the vocal fold oscillations. So overall, these amplified and attenuated frequencies determined by many factors, including the position of the tongue and the size and shape of the cavity. So several research show that patients with cognitive impairment and also other mental disorders often lack a strong control over the vocal folds and the vocal organs, which affect the production of the vowel and consonants. Therefore, it is possible to extract some clues from voice and also from patient language to identify those with cognitive impairment. So here it shows the MCI-ED screen, which we built it on an audio recorded conversation between patients and clinicians. So after this data was recorded, so we have a speech processing algorithm that analyzes the voice and estimate the probability of mild cognitive impairment and early dementia, and store it in the AHR for physician's evaluation, and also finally for adopting appropriate intervention to reduce the risk of negative outcome. But our First challenge for developing MCI-ED screening based on the audio recorded patient clinician verbal communication, especially in home care, which would be patient-nurse verbal communication, is to establish a pipeline for audio recording the conversation. And this is because audio recording is not currently part of clinical workflow. So we evaluated to develop this procedure for audio recording. We evaluated the quality of 7 audio recording devices. There are the 7 audio recording devices, and we selected 3, which this is Saramonic, so black box, and also Sony. These are the 3 devices that we selected, and then we gave it to nurses for further evaluation. All the audio recorded conversation between patient and nurses using these 3 devices were transcribed by Amazon medical transcribe to kind of evaluate the accuracy of audio recorded data by these devices. So we also interviewed with patients and nurses to understand their opinion about the recording procedures, and we found that patients were generally comfortable with being recorded, and nurses noted a possible shift towards more formal interactions with patients. They also recommended the need for extra support to facilitate the recording process during home visit. So the architecture of MCI-ED screen is shown here. So overall, MCI-ED screening analyze the phonetic motor planning of the patient in the voice. So also the level of language organization, emotion, and the way that they interact with the nurses. So here you see that for phonetic motor planning, we use acoustic parameters related to speech fluency, rhythmic structure of speech, frequency and spectral domain, voice instability, quality and intensity. For language, syntactic and semantic level of language organization, we measure recall ability, lexical richness, semantic fluency, and syntactic level of language. For emotions, we use both acoustic and linguistic parameters, especially for linguistic parameters, we use LIWC tool. That is a kind of well-known tool for analyzing the patient emotion. For interaction between a patient and nurse, we use some clues for social interaction, for example, total number of patient turn speaking, dialect interactivity, turn density, turn duration, and relative timing of turns. So to test the performance of MCI-ED screen, we use a publicly available data set they call it Dementia data bank, that it has 166 data for training and 71 data for the test set. So you can see here the architecture of my machine learning algorithm that we use to build the system and the extracted features for phonetic motor planning, semantic and syntactic level of language organization and emotion. And finally, here you see the result, that the result was very impressive with AUC of 90, more than 93, F score of more than 89, recall of more than 85, and precision of 93.75. And if you would like to see more details about the MCI-ED screen, you can see these articles that we explain in detail how we develop these systems. Then we also have several other articles related to audio recording the conversation between patient and nurse and building the algorithm that they will publish in JAMA. So we further analyzed the performance of MCI-ED screen on the audio recorded conversation between patient and nurse in home care. The sample size was 47 audio recorded conversation 47 of the unique patient, and for each patient, we audio recorded 2 to 5. So overall, we had a 125 audio recorded interactions. And the evaluation of the performance shows that the F score for detecting cognitive impairments was 83%. So we also used EHRD data, including clinical node, to build this algorithm for these 47 patients. And we achieved F score 76%, which was lower than the only using audio recorded conversation between patient and nurse, which indicates that the verbal communication between patient and clinician is more informative for detecting cognitive impairment compared to the EHR data. And now the fund that we receive for A2 Collective, so our goal is to fine-tune the MCI-ED screen and the audio recorded conversation between Black patients and nurses in home care. And the reason that we want to do this is that, so based on the data from NIA, so based on the data from NIA, it shows that Black patients are twice as likely as white patients to develop cognitive impairment, mostly because of the limitation in healthcare access and racial biases in examination and lower health literacy. And also by 2050, so the data shows that 42% of US older adults would be racial ethnic minorities, with the cognitive impairment growth highest among African American, highlighting the need for early screening. So and because the dialect of Black patient is in terms of both acoustic and linguistic parameters is different from white patients and other races. So it's very important to fine-tune the algorithm on the specific feature of these dialects. So then we can have a robust screening algorithm for early detection of MCI-ED in this group of patients. So I also would like to thank my mentors, Dr. Topaz, Dr. Julia Hirschberg, Dr. James Noble, and Dr. Kathy Bowles for their valuable guidance for conducting this study. And finally, in conclusion, I would like to express my sincere thanks for A2 Collective funding program and all faculty that they were involved and all staff that were involved in organizing this funding. And also, I would like to thank for your attention to our discussion on the MCI-ED screen. Your participation in this presentation is key and to improving patient care. Although this is a recording session, I warmly invite any question or further discussions. Please feel free to reach out to me for follow-up or to provide additional insight. Thank you so much for your attention. You can see my email here. So I'm looking forward to hearing from you. Thank you.